Okay, fabulous. We are really, really honored to have this opportunity. And we're going to get started because we've got a full session. So, our work is called Voices, Voces, moving forward to address maternal health outcomes. And as I said, a joy to present today. We have no financial or other disclosures. And before we get started, really wanting to acknowledge the full team that makes this work possible, all of the researchers and other staff here at IFS making this possible, and also recognizing our funding sources, CRPH, HRSA through South Carolina Department of Public Health, and the Institute for Families and Society. So, our session objectives are to explore the importance of qualitative inquiry. Carol and I both introduced ourselves. We both use qualitative research for creating learning materials aimed at healthcare providers, as well as sort of developing deeper understanding of the issues that we all are encountering in maternal health. We want to summarize the underlying foundation of the Voces learning modules, which is respectful maternity care. And that is the underlying foundation because that's what emerged from the qualitative data that we'll talk about in a minute. And then we want to analyze a case study together with you to define strategies for collaborative antenatal care with multidisciplinary teams. And that is important because it's a core element of this concept of respectful maternity care. So, just as a quick reminder, we know these statistics, just wanting to highlight that the differences in terms of receiving inadequate prenatal care, in terms of the outcomes around premature delivery and low birth weight delivery, avoidable C-sections, are really predominantly seen among Black non-Hispanic patients and Medicaid beneficiaries. And those are really the voices, as well as recent immigrant Spanish speaking women. Those are the voices that we're listening to in this work. So, a little bit of background. This work started in 2020 and we're continuing it, and it really documents the experiences and perspectives of people using Medicaid to cover the costs of pregnancy, birthing, and postnatal care, and finding ways to put their proposals into action. So the overall goal was to uplift participants' voices in Medicaid related decision and policy making. As I noted, these were the participants, Black and immigrant Spanish-speaking women, as well as community leaders and healthcare providers. And we double-starred that second bullet point because in some of the quotes that you'll be hearing today, we really highlighted your own peers in the quotes. The learning modules themselves, which we'll get to in a second, highlight both of those sets of voices. And let me just say, we launched this work because many of you know that the Institute for Families and Society has been a leader in collating or analyzing Medicaid data to really show statistics and trends over time. But we also wanted to understand who's represented by those statistics and trends. And that's what we've been getting at through the Voices Voces work. So, shortcut to the overall results from the qualitative research. These were themes that came out both through the women's interviews as well as the community leader and healthcare provider interviews. And these are 5 areas. Inequitable treatment was identified, awareness of inequities, both on the part of women and community leaders and healthcare providers, respectful, culturally appropriate care being incredibly important, access to resources and the challenges, and then mental health concerns and access to addressing mental health concerns. So, we're looking at respectful maternity care as a foundation for this work, and really as a window through which we can start to identify and address these other issues, these 5 issues that we saw in the research. So let's just sort of transition now to talking about respectful maternity care because it really underlines the learning modules that we're going to be talking about today. So it's an approach that emphasizes the fundamental rights of women, newborns, and families. And it also recognizes that all women need and deserve, sorry, and deserve respectful care. And we know this. And the questions are, how do we go more deeply in understanding it and really fully putting it into practice or strengthening it when it is being put into practice? Okay, recognizing that this is a heavy slide, but it's an important one. It is the Respectful Maternity Care Framework created by the Association of Women's Health, Obstetric, and Neonatal Nurses. At the end of the presentation, we'll talk a little bit more about the resources that they are offering. But this framework is designed to help hospitals and birthing centers create and sustain a culture of patient-centered care rooted in dignity, empathy, and equity as a standard for every birth and maternal care. So when you look at the center, and we really break this down in the modules, this is just a quick overview. When you look in the center, we're talking about how do we implement this framework? And what A1 is emphasizing is that it requires engagement with the workplace or the system setting. It requires engagement with patients themselves and with community efforts and inputs. So this really means that focusing solely on clinical settings, be it hospitals, birthing centers, is not sufficient. And so we need to connect those efforts with community initiatives and community-based professionals, including, for example, doulas and community health workers. The framework acknowledges that the care team, as you can see on the left-hand side, the care team and the members and patients, as you see on the right side, they really meet one another with backgrounds and experiences that shape patient-provider interactions. For the care team, these range from organizational culture, in which where members work to enact their lived experience, and their professional experience. For patients, factors range from personal expectations, right, of their care providers to their level of self-determination to really be able to advocate for themselves. And that's going to vary from person to person. As a member of the care team, really, this framework emphasizes meeting patients where they are through awareness of patients' expectations, experiences, knowledge, culture, and self-determination, and acceptance is key to putting respectful maternity care into practice. Lastly, mutual respect and shared decision making are more likely when care providers put awareness and acceptance into action. And you can see in those little bubbles there the word bias that can interrupt these processes and have a negative impact on respecting the basic rights of patients. So that in sum is the respectful maternity care framework that A1 has put together and that we are using throughout this work. So in sum as well, respectful maternity care, or RMC, goes beyond being kind or polite, which is also very important, but it's a professional and ethical obligation. It's a systems responsibility. So we can't see this as an individual responsibility. Individuals working as well as with systems that are committed to enacting and implementing RMC. And then clinical quality and safety issues that must not be overlooked is really key to putting this into practice. So pivoting to a quote from a much longer interview with a family physician who offers OB care, that to listen to Black women, to listen to our patients, and to figure out a way to match what I have to offer with what they need. I think listening and hearing what the needs are of our patients, and then being able to accommodate that, maybe even over our original plan. So that's been probably the most important thing because it makes us think or ask the question, well, what else are we doing that doesn't fit the needs of our patients? And how do we become more accommodating and flexible with that as well? So why is respectful maternity care important? In the literature, including but going beyond A1's work, it really protects and fosters maternal and infant health while improving outcomes, contributes to preventing traumatic experiences, And unfortunately, we heard a lot of those in the interviews, and really builds trust between patients and the health system, which I think many of us have discussed in our work. And it will be part of our discussion today of where that trust comes from and when it's broken. A community health worker working with a local, statewide organization, PASO, says the main barriers I observe, especially with communities with low literacy rates, primarily from Honduras and Guatemala, are first that they can't read. Some don't even speak Spanish. And there's a degree of shyness. There's a degree of fear. They're changing cultures. So they need people they trust, people who love them, people who respect them, and who give them peace of mind. We build a bridge between the Latino community and health services. And he really emphasized that building of a bridge being so important, going back to the A1 framework, that emphasis on implementation needing to include the community organizations and community resources. And then what happens when respectful maternity care is not put into place? These are just a few examples. All of us have seen our South Carolina Maternal Morbidity and Mortality Review Committee briefs. This is from the 2026 legislative brief, which analyzes data from 2022, 2023. Here we're highlighting the dimension or the circumstance of discrimination being, according to the review committee, the possibility of discrimination is described as treating someone less or more favorably based on group, class, category they belong to, resulting from biases, prejudices, and stereotyping. It can manifest as differences in care, clinical communication, and shared decision making. So in this case, in this report, the prior report had a higher percentage. In this report, it was 8.3% of all maternal deaths or pregnancy related deaths, finding discrimination to be part of the circumstances of that death. I think we really need to give a shout out to our Maternal Mortality and Review Committee for looking critically and really looking deeply into the kinds of data sources that they review to bring this to the forefront. And it's something for us to pay attention to acknowledge, but it's also a point of launching, okay, what do we need to do to address this? Another impact or result of not putting respectful maternity care into practice include missed opportunities to understand patients' life situations. From a social worker that was part of the Voces work, she said, one of the other things is a lack of awareness. Keep in mind that we work with rural and underserved populations in her particular organization. So when you're in rural areas, you're challenged by a lot. Transportation is one of the biggest challenges that they have, meaning patients. So for you to schedule an appointment for someone who does not have transportation at a time that doesn't make sense for her, you're setting her up for failure because you know she's not going to come. So really, recognizing those life situations and figuring out what can we do to really meet the needs of this and the possibilities for this particular patient. Missed opportunities also are related to missing, sorry, not putting RMC into practice also is related to missed opportunities for early initiation of prenatal care and continuity of care throughout pregnancy. We know, as I cited in one of the first slides, but according to the report by the South Carolina Institute of Medicine and Public Health, their report in 2023, that once again, 1 in 5 women experienced inadequate prenatal care. And that's using the Kotelchuk index of adequacy of prenatal care utilization, which the definition is there on that slide. So the recommendation from our own review committee is that all pregnant and postpartum women should receive health care that is respectful, non-judgmental, and non-biased and considers their cultural differences. So in large part, that's why we're doing this work. And we are really so, again, honored to be part of the Project Echo session today, which is part of the fuller strategy of developing the maternal health workforce as part of the South Carolina Maternal Health Innovation Collaborative. So it's, again, exciting to be part of that larger initiative. So, sorry, just so what I'm going to transition to now is looking very briefly at the modules that we are creating, these online modules, and then we'll talk at the end about some of the in-person um, possibilities that we have in place. So the learning modules right now, the global title is Respectful Maternity Care Learning Modules. We'll see at the end that we will probably be shifting that overall title so as not to confuse what we're doing here in South Carolina with some of the other materials. It's been very exciting to have a wide variety of health professionals, healthcare related professionals who also have background in learning and pedagogy as part of our advisory committee. So just a shout out to this group of people that have been with us and offering really critical, really insightful comments so that we can make these online learning modules interactive and as useful as possible. So before I just show you the titles of uh, the different modules, I want to make clear that every module contains the following components. We'll have learning objectives, definitions, quotes that are text and sound files from the interviews, the Voces interviews. We'll have South Carolina specific statistics. We'll have knowledge checks, reflections based on scenarios that are presented, and then a section that is an action plan where we link the content to REDCap. We ask at the end of each module that the participant define one feasible action that's related to the content and what are the resources that they would need to carry this action out and what is the timing. At the end of that module, you'll receive a certificate. You'll also receive a PDF of that action plan component so that if you go through all 5 modules, you'll have 5 actions that will come to you so that you can follow up on that and use that as a guide for yourself. Okay, and then we'll offer a section on related resources. So the modules themselves are framed, the titles are framed as questions so that it's really, you asking the question and hopefully raising interest in going into these modules. So the first is, what exactly is respectful maternity care? And actually, why does it matter? And so really focusing on setting that foundation. The second module, how do I offer the highest quality, respectful maternity care to everyone that I serve? And this really focuses on putting respectful maternity care into practice and addressing implicit bias. The third module, how can I better listen to, hear, and communicate with my patients? And we're really breaking that down into 3 different skills, and 3 different modalities for interacting with patients, all 3 being very, very important. The fourth module, how do I identify and address patients' challenges to accessing care? And there we break down the different dimensions of access and really offer some very concrete suggestions. And then 5, how do I work collaboratively with other professionals to ensure my patients receive quality care? So this module is focused on collaborative teamwork across all clinical and community providers. And as we shift to the next section, we're going to dig a little more deeply into what that means. And then we'll go into a reflective exercise, a more participatory exercise, and that's when we'll stop the recording. But first, I want to transition to Carol Reed so that we can dig into how do I work collaboratively with other professionals to ensure my patients receive quality care.
So, as we talk about collaborative care, we recognize that one profession cannot do everything by themselves. Next slide, please. And we know that collaborative care is a critical component of high quality maternity services, particularly in rural communities where barriers to access and limited healthcare professionals are common. Respectful, patient-centered maternity care ensures that services remain dignified, responsive, and aligned with each individual's values and needs. We know that this approach is most effective when delivered through collaborative multidisciplinary teams that include obstetricians, nurses, midwives, doulas, community health workers, social workers, and other professionals. The multidisciplinary teams bring together individuals with diverse experience who work collaboratively to provide comprehensive, high-quality care. Each member contributes specialized skills and perspectives, united by the shared goal of promoting the patient's overall health and well-being. Working together, these teams serve as interdependent components of high-quality, safe, and equitable maternity services. Rather than focusing on mortality prevention, multidisciplinary care promotes a comprehensive birthing experience that honors decision-making authority, individual preferences, and lived experiences while supporting optimal clinical outcomes. Strong teams are built on active listening, clear and respectful communication, clearly defined roles, mutual respect, shared goals, and a strong commitment to teamwork. Next slide, please. Collaborative care is essential because maternity care addresses not only physical health, but also emotional and social needs. We know that systemic constraints such as billing structures and limited appointment times remain significant challenges. However, collaborative teams help bridge gaps in care that might otherwise go unmet. Ultimately, trust, personal connection, and sustained relationships are central to delivering truly respectful and effective maternity care. Next, Debbie will present our case scenario.
Thanks, Carol. Okay, and we are a little bit ahead of time, so this will leave us even, I think, some additional time for discussion. So the idea here is that we are going to show a clip, a 2-minute clip of of a monologue that was recorded from a larger theatrical production. Um, Part of the background that I sort of skipped over is that we worked with a playwright from the very beginning of the Voces project, and she really helped to shape the interviews into a theatrical piece that was performed several times in 2021. That was also recorded and enabled us to offer materials to anyone that wants to use them on SC Health Biz of the full theatrical performance, as well as a breakdown of several monologues that highlight particular issues that were really central to and that emerged from the research. So, what we're going to do is listen to a 2-minute clip from this larger monologue video. I do want to preface this clip with saying, part just for respecting everyone's time and making sure that we have time for discussion, that we're not playing is her explaining that she left a domestic violence situation, traveled via bus from North Carolina to South Carolina, where she found out that she was pregnant. There were no shelters that would accept her, and she spent time while being pregnant living on the street in Five Points. And so that's part of the background context of what you'll hear in the next 2 minutes. What we're going to ask, and Rachel, I imagine maybe after the video, this will be the part that will where we turn off the recording. But what I will ask is that as the video is playing, that you take a look at the 4 questions and maybe even jot down some notes so that when we launch into the discussion, we're basing our discussion on these 4 questions. We might not get to all of them, and that we'll be able. And I'm going to stop sharing so we can actually look at each other as we discuss.
So before you press play, just as a friendly reminder, we never record participants or the chat or discussion. That is purely just for those who are able to make it live, and everything that goes on our website is solely the presentation slides and the person presenting so that we have a safe environment to chat. What I'll do is copy and paste these questions into the chat, but you can feel free to start chatting in so that we can just get right into it as we go. But feel free to
Okay.
chat, just not to speak right now. Okay.
Okay. Great. Thank you, Rachel. All right, let's go.
Considered high-risk pregnancy. Then I made sure they had my insurance. I have healthy connections. I had already been on Medicaid because I was in foster care, so I don't want to make it seem like I got the help all by myself. I had already had that help from being a foster child. Then coming home, after having my baby, after I had a C-section, it was really hard because I didn't have any support and I had to do everything on my own. I feel like I should have went home with maybe home health care, knowing that I was going to be dealing with the baby by myself, carrying everything. I was going to be leaving the hospital on the bus, getting to the hospital on the bus. Then coming home for my second surgery, which I feel like could have been prevented because after your first surgery, you had your one-week appointment. And I was telling them I didn't feel like something was right. They were like, oh no, it's okay, it's going to be a little green. I was like, I feel like there's a funny smell down there, I think you guys should check it out. Oh no, it's fine. Then a couple weeks later, I told them I feel like something was ripping or tearing. Then they sent me straight to the hospital. They left me there for about 8 hours. Didn't really take it serious when they were supposed to get me immediately sent to a CT scan. But they let me sit there. Then finally, when they did put me in the room at like 3 in the morning, actually being rolled down to the CT machine, my stomach busted wide open. It still took them 3 or 4 days to get me into surgery. So yeah, the second time was even worse. They kept telling me, it's okay, it's okay, it's okay. But you know your body, you know what I'm saying? I knew that something was wrong. But they didn't want to listen to me. So that was really frustrating as well because this could have been prevented.
Okay, so I'm going to stop sharing so that we can launch into the discussion.